Good morning. I'm going to stay off video this morning because I'm teaching from home and I'm still in my running Lydia to school clothes. I haven't changed into my teacher clothes yet. So I was trying to find lots of COVID stuff for you guys since this modern disease profile piece was written obviously pre-COVID. So I wanted to see if I could find some of the latest stats from the last couple weeks or whatever. So still in my pajamas. Fancy pajamas, drive kid to school pajamas, but still. So we'll just do that. The other thing I needed to mention is that next week we are returning to the classroom, theoretically. I have not given you guys the update yet, and I was going to do it this morning, but banner's down. What we're going to do is split you in half alphabetically. So the A to whatever in the middle is the split goes on Tuesday. Middle of the split toward the end goes on Thursday. We will keep recording lectures, and to be honest, if you are not comfortable in the classroom, do not go to the classroom. I know that we're supposed to be forcing you to go to the classroom by taking attendance and locking you out of Zoom meetings if it's not your Zoom day, and all kinds of other mean strategies that they told us to use. But I'm not going to do that. You guys are grown-ups, and if you are not going to the classroom, then you have your reasons. And I know that some of you have small children and maybe people in your households that are immune compromised and all of that stuff. So I'm basically going to keep going like I'm going, except that there'll be a few of you guys in the room on Tuesday and Thursday. I think I have it figured out how to project to both of you. I have like 2 mics. So we'll see how that works. If they don't squeal against each other, I think I can get where the computer people can hear me and the classroom people can hear me. And all of it will be recorded and it'll all be the same class. Everything is still turned in through the computer. So I think that's it. But I will put an announcement that has the split so you know what days you are, whether you're a Tuesday day or a Thursday day, on paper at least. So we have to do this on paper. We just sign up at the registrar's office and do the changes and everything, but it's on paper. So not necessarily, remember that difference between ideal culture and real culture? So the ideal culture is what I sent to the registrar's office. The real culture is, if you're comfortable coming to class, come to class. If you're not comfortable coming to class, don't come to class. I will not be forcing you, and I will continue to record. All right. Excuse me. So modern disease profiles as we continue on. This new rise in infectious disease. Imagine that. Part of it is because of antibiotics and drug-resistant antibiotics. The rise in tuberculosis and drug-resistant tuberculosis is a real thing. Growth of cities, globalization with business and travel, erosion of cultural traditions and environmental changes. A lot of the stuff I was reading was expansion of cities, putting large populations really close to trees, essentially, putting them really close to the boundaries between nature and city and having a lot of people straddling that boundary. It's something that contributes to fires. It's something that contributes to viruses, because if you think about tribes living further away from each other, communities living further away from each other, that bat that gave people COVID, I mean, somebody might have eaten that bat that gave them COVID, but it might have just stayed within the small community that they lived in, instead of that bat making its way to an urban market and then being consumed by somebody within an urban area. And then due to global travel and environmental changes and everything, we end up with COVID-19. What we have here? So a few things on COVID-19. Slides, the things I was looking up. I did not find really good case fatality and infection fatality rates for the Delta virus. All I could find were the earlier ones where they were concluding it's not as bad as we thought it was, but I've not found any good stats for now. But anyway, case fatality rate and infection fatality rate are different things because the case fatality rate are identified cases. People go get tested. They are in the system. They are recognized by doctors' offices and stuff. And they are official cases. So if one person died out of the 4 official cases, then it is 25% case fatality rate. The infection fatality rate is going to assume that there are people that we don't know that have it. That's where it gets a little bit tricky to try to figure out what exactly the infection fatality rate is. Sometimes they go looking at excess death measures. Excess death measures are a really good way to look for the real COVID toll and the real metric, but we don't have too many good excess death rates for the Delta variant. So we don't know for sure what that is yet. So at a 7, that would be a smaller than the case fatality rate, the infection fatality rate would be. And I have a calculator. So 14.2%, which is a lot better than 25%. But do you really know the infection fatality rate? You know, who knows? Who about these gray people? You know, maybe they are, maybe they're not. So case fatality rates versus infection fatality rates. You'll see those numbers thrown about when we're looking at COVID. Other things about COVID, the case fatality rate was dropping before Delta, and who knows what the next one's going to bring, because Mu is coming. Apparently Mu is in every state, but they are not too sure that it's any worse than Delta, but theoretically it impacts vaccinated people more, but you don't get as sick. I think was the last thing that I saw was Mu. I'm like, okay, I don't know if I want to know at this point, but that was the last thing I was reading about that one. So the textbook has main causes of death from 1900 to 2016, where influenza and pneumonia in 1900 were a main cause of death. Heart disease was the main cause of death. In 2016, tuberculosis got taken over by cancer, diarrhea and intestinal ulcers got taken over by accidents. And you can see the general trend toward chronic diseases, accidents, rather than acute illnesses, influenza, tuberculosis, various different diarrheas and intestinal things. Instead, you have heart disease and cancer. So lifestyle kinds of illnesses kill people at high rates in the modern age than they did in the 1900s. So, there it is. So what happened with COVID? Where does COVID fit? COVID fits number 3 for 2020. So heart disease is still number 1, cancer is still number 2, but we throw COVID in there. We still have influenza and pneumonia, so you're always going to have influenza and pneumonia deaths. They stay about the same from year to year, but COVID deaths were 345,323 in 2020, and that put them into 3rd place. So kicked a bunch of other people out. Unintentional injuries is what they call accidents now. So they changed that naming, but it's the exact same thing. It is the unintentional injuries. This is from the National Center for Health Statistics, mortality statistics from the CDC. Data for 2020 are provisional, so it's not, you always have to go back and confirm, but that's what they have for right now. And deaths confirmed or presumed have COVID as the underlying cause of death on the death certificates. That's how they come up with these numbers. So I think I knew it was up there, but I couldn't remember which place it was. I knew it was up within the top 5, but I couldn't remember where it was. So new cases and deaths, this is like today. So I took this one 14 hours ago. It's the one from the New York Times. It's available this morning. Now, one of the interesting things they do is they have a different between what they call the new cases and the 7-day average, because you can see some little pale blue spikes. And I put the new cases and 7-day average in here. So you can tell which is which. That was April 25th, just by chance. And especially since the summer, look at these really inconsistent reporting where you have huge spike, not a whole lot, huge, not a whole lot, huge, not a whole lot. You have states that don't always want to report. A lot of days you have states that are not reporting at all. I think Nebraska is one of those states that's not reporting at all, because when you see the statistics across the country, you see all the different states that are reporting their stats, and they're all different colors, and then Nebraska is like nothing. So like, report. That's the sociologist in us, right? If we can't do anything if we don't have numbers, if we don't know what's going on, it's really difficult to formulate any kind of response. So they do use the rolling average to kind of catch the middle here. So the average over 7 days. So it's going to change every day just a little bit. So as cases go up, the rolling average also goes up. Nobody really reported over the weekend, so the rolling average went down. That's pretty typical on a Saturday. I think like 20 states recorded, if I remember right. Like hardly anybody reported. Not much recording yesterday. We'll probably catch up Wednesday with a fairly accurate case reporting on it. You can see the surge. This is what is it? Excuse me. Fourth wave, right? You get the first little wave in May that we thought was so horrible. Then we got the little bit of summer wave last year, and then we got the oh my goodness up and over the holidays wave, and then we're like, ooh, we figured this out. We have vaccines and everything, and then never mind, here comes the Delta variant. So that's the way that the cases are going, new cases and deaths. These are not the deaths, these are just the new cases. I did not click on the death chart. Here's where your hospitals are unavailable to you. The darker the red, the worse the ICU situation is. Now, we do in Huntsville Hospital theoretically don't have any ICU beds, but they're managing to scrounge some. And it says 10 to 20% of hospital beds are occupied by COVID-19 patients, and that's an awful lot. You guys have probably seen the stories of somebody with gallbladder disease who died waiting for a hospital bed. I read a story last night, a journalist in Virginia, someplace up the East Coast. Yeah, no beds in Crestwood. Oh my goodness. That doesn't surprise me, I'm just like, nobody do anything, so we don't need to use the hospital. My husband needs heart surgery. He's older than I am. He has a heart issue, and he needs open heart surgery. And they've been putting it off for a year now. And they just have to screening him because they're like, we're not going to put you in the hospital right now. They can't. There's no ICU beds. They can't do open heart surgery on somebody right now. So he just has to be, he has an aneurysm. So he has to be really careful, no lifting things, no running, no jumping, anything that would stress the heart and cause that thing to burst. But in the meantime, we just wait. He's back at the doctor this morning getting it scanned and sized. I mean, at some point, they're going to do the surgery regardless. But at this point, they're not. So yeah, it's impacting regular people. I saw the case of a 10-year-old with appendicitis who had to wait because there wasn't a room for him in the emergency room. And while he was waiting, his appendix burst. So when the anti-vax people are saying it's not infecting anybody except for them, it is. It's affecting a whole lot of people besides just them. So Crestwood has nothing. I say this is like really trivial. I try to get my child a sports physical, and we had 3-hour waits everywhere trying to get a sports physical. But it does impact the system, and when it impacts the system, remember functionalism, that everything stays in balance. And when something starts getting part of the system out of whack, everything else has to rebalance accordingly. So things don't operate in isolation. It impacts everything. And that's something that I don't know that a lot of people are getting from this. They're like, yeah, so the COVID people there. They're like, yeah, but that means like there isn't any room for anybody. It doesn't matter what you have done to yourself. Fall off a ladder, whatever. You're not going to get a bed right now. And there's nothing that you can do about it unless you start rationing healthcare. And they're going to have to do that pretty soon, I'm sure. They're going to have to start picking and choosing and looking at who has the best chance for recovery and assorting beds in that way. I'm not going to be surprised. Which makes me still kind of surprised that we're going back to the classroom next week. I have 0 hospital beds in town and they're sending us back to the classroom. So that's why I'm saying you are not comfortable. I will not be forcing you to the building. I will be there because I have to be there. But I will be masked up in my AN95 and all of that good stuff. So I should be all right. And my husband is vaccinated and getting the booster shot soon. So, we are not high risk people. So I will be going. But, if you have any connection to anybody who's unvaccinated or high risk, don't come. I mean, there will be no forcing by me. I don't know what the other teachers are doing. I know Miss Burnell is not forcing people to come. So if you have the 2 of us, you should be okay. Some of the other ones are being, we're being told to be mean, but I don't know that we're going to all be mean. I don't think it's fair to be mean, right? Here's our Madison County cases as of yesterday, because I pulled this chart this morning. So Madison County has had 45,548 cases and 556 deaths. Jefferson County, Birmingham area has had 105,000 cases, 1,670,000 deaths. Alabama is up and over 12,000 deaths and 725 cases. This is really unimaginable numbers from when this whole thing started, right? And I remember that week before it started, if you were in any of my classes that week before we all got sent home, I gave a coronavirus lecture. Here's this new disease. It's starting to make its way over to the United States. And like a week later, we got shut down. And I remember the first case in Alabama, the first death in Alabama. Did any of us really expect that it was going to do this? I mean, part of me did. Just knowing epidemiology and knowing public health and knowing how Americans are incredibly not idealistic, we're that too, but individualistic and don't want to be told what to do. It doesn't surprise me, but it's still bigger numbers than I think I had expected. I still kind of can't believe that it got this far, 12,000 deaths. We have, 250 cases of COVID in the Huntsville City schools right now, new cases, but they're still going. My daughter's there. She's masked. She's in school. It's just a whole new world from a year ago. It's amazing what a germ can do. It's just a germ. That's all it is. But it impacts human behavior. It impacts culture. It impacts everything. It has made us much more divided. Politically speaking, I don't want to say it brings out the crazies, but it kind of does. The plague, they had the flagellators that would go from town to town, whipping themselves to get rid of the plague. So you've always had fringe groups whenever you've had epidemics. But I don't know. I always think that maybe it's wishful thinking on my part, but aren't we like modern enough to not do these things anymore? But every single time it's like, okay, we're just humans. Even if we have cell phones and all that cool stuff, we are still humans, just as humans were during the plague years, and we do in the 1400s, and we still do what humans do when plagues and epidemics and pandemics come. So here's a couple more charts. This is the Johns Hopkins cases per population, or deaths population. That's it. not necessarily the most deaths. So deaths per population. Mexico has the highest number of deaths per population by a whole bunch. Now, the other thing to think about is, reporting. So some of these countries do you have a full reporting of deaths from COVID per population? Now, the US is down here at, goodness, can I zoom? Probably not. Zoom in. Those are small numbers. 1.4? Looks like 1.4. France 1.7. US 1.4, I believe. But still, it's per population. Some have, with more testing, more cases are identified, so you can get a lower ratio. Healthcare system, mortality rises as hospitals become overwhelmed. Mortality tends to be higher in older populations, but not necessarily with the Delta variant. Sometimes I wonder if the Delta variant hit us first, would we have had a different response to COVID? Because the first wave, that Alpha variant, hit the elderly really high, I kind of wonder sometimes if it was hitting the kids, do you think we would have taken it more seriously? And then here we are 18 months later, and now it's hitting the kids and the young adults and everything, and we're kind of like, numb at this point. Nobody's, and if there is any reaction, it tends to be the anti-maskers and the anti-vaccine people that are the squeakiest wheels right now. And even deaths of teachers, none of that bothers them. There are 15 teachers in one district in Florida that died within a week. And yet they still go to school and they don't have mask mandates. So it's just interesting, right? So these are the old variants. This is pre-Delta. I wanted to find a nice little variant chart. So viruses always evolve. They constantly evolve because germs want to live. Sometimes the mutations give them an advantage. Sometimes it gives them a bit of a disadvantage. Those mutations that give them an advantage tend to become desirable mutations. They will go into more bodies and they will, recreate themselves and spread a lot faster. The more bodies there are to catch COVID, the more mutations you get. That's one of the issues with anti-vaxxers. If we had herd immunity, if we had enough people vaccinated, then we'd have a few cases here and there, but we still have cases, but the viruses wouldn't necessarily have that nice fertile ground to mutate. They would be getting fought as soon as they entered the body because you would have antibodies and you would start fighting against them. Even if it wasn't completely effective, even if you get sick, you have antibodies that fight against the virus. It's the bodies with no antibodies that are the fertile ground for the mutations. And these types of SARS viruses just mutate constantly. So it's not a surprise that we are getting mutations that make them more transmissible, sometimes severity. This is the Brazilian variant here in January that everybody was concerned about. There's the Colombian variant is the one that's possibly mu, and I think I have that on another page here in a minute. But this is what they do. So the September 2020, the British variant had increased transmissibility and increased severity. Still didn't really hit the kids, so not too bad. The South African variant came out about the same time as that one. That's why we were still calling them B117. This one, I believe, is beta now. This one is whatever comes after beta. I never learned my Greek alphabet. But that one, in South Africa, increased transmissibility, possible reduction of vaccine effectiveness. Now, the mu has even more vaccine issues, but I don't think it doesn't make you as sick, and it's possibly not as transmissible as Delta. So, but again, you got to have numbers and data to figure out these different things. Okay, so here's my weekly epidemiological update. I've got that here. I will, that one, yes. Throw that here somewhere so I can share screens. There it is. I have 500,000 tabs open right now. There we go. I did a couple of screenshots there. You can probably see my 500,000 tabs. So, okay, so why did we not? There we go. Download. Open with Firefox. There it is. Okay. So you can see what comes out. Let me share screen and you can see what comes out once a week from the World Health Organization. We'll look at a couple of things. And then we'll get back to epidemiology in general. Okay, where are we? There we are. Nope, that one. So World Health Organization puts out a document every single week. This was the 31st of August one, 4.4 million new cases from the 23rd to the 29th, holding pretty steady. So a lot of them are kind of holding steady and or declining, except for the Western Pacific region. 67,000 new deaths globally. And then here's the nice little chart that shows the Americas, Southeast Asia, Europe, Eastern Mediterranean, Africa, West Africa, Pacific, and deaths is the line up here. So that's the one chart. And the other thing to think about with some of these are, if you don't test, do you know you have cases? That's one of the issues. So that's where they start looking at, especially the Financial Times of London has been doing a lot of research into what they call excess death rates. They go back 5 to 10 years for months because they tend to be reported by month, and look at the differences between, like, the average number of deaths from 1990 to, that's too far back. 1990 is too far back. 2005 maybe. 2005 to 2018, see how many people generally die by month. And then they look at the reported deaths in that area. And that's where they're catching some of the COVID deaths that are not being reported as COVID deaths, because you can make a fairly educated argument that excess deaths are COVID deaths. Maybe not all of them are, but a good number of excess deaths are going to be COVID deaths compared to who generally dies, because people tend to generally die at the same rates from year to year in the modern society, from month to month. So they're using that kind of data to tell us the real COVID numbers. Here's a bunch more. New cases in the Americas, cumulative deaths. Global, we're at 4,490,753. Here's the hotspots. We are not the darkest maroon like we were last week. So we're slightly better, just the tiniest bit. Not much, but just the tiniest bit better. Here's deaths per population in that last week of reporting. And yeah, that's it for this one. And then they have the variance trackers that they do also. Now, these are a little bit, where are we at here? So variants of concern, alpha is the original one, beta, gamma, delta is the one that we're really concerned about. Oh, so alpha is never mind. I always thought alpha was the first one. Alpha is the first British variant. So alpha is the British variant, beta is the South African variant, gamma is the Brazilian variant, delta is the India variant. So those are the ones that they are tracking. And these are more amino acid, microbiology-ish things. And then here's the variants of interest. Eta, iota, lambda, and mu. So mu is the one that I've heard of. Lambda got a little bit of press. fairly recently, but mu just got named. So that's the one that they're looking at right now. And then actions taken. So that's some of the current updates on the great coronavirus. We'll get back to just plain medical sociology. There we are. Share files, do that. I think that's all I had. Yes, that was it. So that's the updates on the coronavirus from the epidemiological perspective. We will throw it in there from time to time based on the other perspectives as well, but that's the epidemiology one. So preventing, back to our pre-COVID notes, preventing premature deaths. You have to look at the manufacturers of illness. Where do illnesses come from? What are people dying from? And then focus on prevention. So these are premature deaths. And these are premature deaths are basically deaths that are not expected times. So you expect people to die at certain ages. And if they are not dying at certain ages, if they're dying much younger, then these would be, kind of unexpectedly early deaths. So diet or activity, tobacco, medical errors, alcohol, bacteria, viruses, toxic agents, etc. Could not find the COVID numbers on here for premature deaths. So what are the manufacturers of illness? We look at tobacco, diet, medical errors, alcohol, bacteria, viruses, toxic agents, and we focus on reducing people's exposure to these things in order to keep them from eventually getting the conditions that would result in premature death. Health belief model. So this is a big deal. This goes all the way back to Bourdieu and his belief in the habitus, that idea that each layer of society, each socioeconomic status, essentially has its own culture. Now, the health belief model then goes a step further and says every socioeconomic status has its own health patterns, lifestyle patterns that will either predispose it to early death or have a preventive effect for early death. So the health belief model in general is that people will adopt healthy behaviors when they believe that something will kill them. They believe the risk is serious. They believe that compliance will reduce risk and have no significant barriers to compliance. So you can see that these may vary by socioeconomic status, so that each socioeconomic status would have a different model, basically different perceived susceptibility, different perceived risk, different beliefs in compliance and ability to comply, and especially the number of barriers to compliance would be different across the different socioeconomic status. So that, so health lifestyle theory goes a step further there and says that it is structure over agency. So yes, you make individual choices. A health belief model is focusing more on individual choices. Health lifestyle theory pulls it into that Bourdieu habitus neighborhood that says that yes, you make decisions, but your decisions are bounded by the culture that you live in. Kind of a Georg Simmel thing going on too. So, it's like you believe that exercise is going to be good. Exercise is good. You should do it to help your health. Depending on what social class you're in, do you have the money to pay for a gym? Do you have the ability for people to watch your children while you work out? Do you have a job that you sit all day so that you need to work out? Or are you working a construction job? People who are working construction jobs are probably not going to go to the gym after they leave their construction jobs. So they're looking at group structural type of differences that lead to health behaviors. So living conditions would fit within health lifestyle theory. Demographic circumstances. There was a big study in Maryland, believe it was Maryland, by Johns Hopkins, because that's where they are, looking at asthma in low-income children. And one of the things they were able to trace it to was the presence of really, really nasty carpet in old buildings that people of lower socioeconomic statuses could afford. So they could afford to live in buildings that were a bit run down and had just really nasty carpet. And when the Johns Hopkins and the public health people were able to convince the property owners to switch it out with like laminate or vinyl or anything but carpet, the asthma rates dropped dramatically. That's a structural thing, right? You can afford to live in places you can't afford to live in healthy places. You're living in unhealthy places because that's what you can afford. So that's a structural issue. What type of housing is available to people at what price points? Demographic circumstances are going to be there. Living conditions will be there, and cultural memberships. What is your culture? Is your culture food-based? Is your culture not so healthy food-based? Is your culture drinking-based? Is your culture like trying to get Italians? I don't want to stereotype Italians, but trying to get Italians to quit eating pasta and drinking. Going to be very difficult because that is part of their cultural membership. Trying to get Polish people to quit drinking. That's why my brother makes a living, because they go to the bar and they drink and they buy his food. So cultural memberships are going to impact your health lifestyle. Is this a culture that regularly drinks and is seen as approved, or a culture that does not? And then what types of foods do you eat within your culture? Not a whole lot of kale across the Polish people. So health lifestyle theory looks at demographics and all of this stuff. Life chances, life choices, back to Georg Simmel. And then socialization and life experiences go to choices. And then your disposition toward health behaviors, and then your pattern of your healthy and unhealthy behaviors. So your dispositions are like, do you even like kale? Those kind of habitual dispositions. Are you generally a vegetable eater? Those kind of things. And then your patterns of healthy and unhealthy behaviors within the culture. Do you have access to vegetables? That goes back into the housing, food, neighborhood safety thing. So it might be that you love them, they're just not available to you. So we have to look at that choice, chances, dialectic continuously with health lifestyles, especially when we get into chronic illnesses. Social stress as cause of disease. There's chronic stress and acute stress. Lots of articles now on the chronic stress of being 18 months into a pandemic. Tons of articles on that. So you can look at those if you want to. Responding to stress. How do people respond to stress? And these all combine to produce an individual's cumulative stress burden. And then that cumulative stress burden then impacts health. So basically what you have is a stress model where you have stress on the one side, you have you in the middle with your coping and social support opportunities to you, and then at the end of it, you have whatever happens with your stress, depression, anxiety, illness, viral illness, susceptibility to disease, addictions, and there's one more, but I couldn't remember what the other one is. Addictive behaviors, and so on and so forth. So, there's going to be way more studies, but right now they're looking at the responding to stress of 18 months of living different. Now it's almost feeling like it's a regular life, right? I remember the first couple of weeks of being sent home, and we were all home, all 6 of us in the small house, and thinking, when this 2-week shutdown or 3-week shutdown is over, what parts of this do I want to keep and not keep? We had time to make dinner, we ate together and some of that stuff. And I was thinking, what part of this is kind of nice and we want to keep this when we go back to normal life. And we're not in normal life yet. We're just kind of having this odd kind of in the middle, right? Like the entire world, the society is trying to be like nothing is ever happening, like nothing happened, there is no COVID, go back to school. But the reality is that it's still out there. We are just kind of running around with blinders as a society, pretending it doesn't exist. Deaths are happening inside of hospitals, and due to HIPAA violations, we can't see it. And none of us can see the reality of what's going on inside the hospitals, except for the people inside the hospitals, because they can't film, they can't share, they can't really tell what's going on. They can come outside and tell us. There's been plenty of doctors and nurses telling people what's happening, but there's some element of having to see it to believe it. You have people saying, well, they're just telling us that. It's not real. It's still a hope. It's not real. And it's hitting healthcare providers now to the point where last night, the UAB night shift nurses would not clock in. They protested because the pay wasn't high enough, the patient loads were too high, and you need a break at some point. Somebody got to get paid more. You need to have more nurses. You need to have more support. And at this point, in 2 hours, the health professionals get a moment of silence because we're going to have a statewide silence at noon for the 12,000 people that have died. But does that really do anything? It's just kind of barely a tiny little Band-Aid on this bleeding, gushing wound, basically. So, teaching medical sociology last fall was different than this fall. It's like last fall, it's like, okay, we're going to get our vaccines. It'll be good. We'll be back to normal. And this fall we're still doing this, seriously? So who knows what it's going to be next fall when I teach medical sociology. Anyway, that's it for the day. When I can get into banner and count how many of you guys there are and get that middle name, I don't put the entire name up there. It'll be like A through LE or something. So I'm not going to put your entire name on there, but I'll put enough alphabet enough letters so that you can identify yourself as being a Tuesday person or a Thursday person. And again, you don't have to come. We just have to do this. Any questions? Everybody else as grumpy as I am because it feels like a Monday? Probably. It's a very Monday-ish Tuesday. Okay. So if we have no big questions, I'm going to let you guys get out of here, and I will see you on Thursday.